My name is Patricia. I'm the Operations Manager for the Alberta Transplant Institute. So good afternoon and welcome everyone. This is the first ATI seminar of the 2021-2022 weekly series. And we're very pleased to be relaunching the series with the generous support of Paladin. And I know some of our colleagues from Paladin are on the line, so welcome to you. Paladin is supporting not only the seminar series this year, but some other ATI activities as well. And we'll be sharing further details about those very soon, so stay tuned. So it's my pleasure to introduce our two speakers today who are joining us from the UK, Mahmud, Nawaz, and Dr. Dale Gardiner. So Mahmud Nawaz, we'll hear his story in just a moment. Mahmud lost his wife very tragically in 2004 when she was just 32 years old. She became a donor of 2 kidneys and a liver, which saved the lives of 4 people. Mahmud's day job is for Lloyd's Banking Group, and over the years since his wife's passing, he's increasingly become an advocate for organ donation awareness and improving practices, including training ICU physicians on how to work effectively with donor families. He sits on the organ donation committees for the Mid-Yorkshire and Leeds Hospital Trusts in England, and volunteers as a donor family ambassador with the NHS Blood and Transplant Ambassador Program. Dr. Dale Gardiner works in the UK as well. He's originally from Australia, but migrated to the UK in 2002, where he's currently the Associate Medical Director for Deceased Organ Donation at NHS Blood and Transplant and a consultant in Adult Intensive Care Medicine at Nottingham University Hospital's NHS Trust. His professional interests are medical ethics, the diagnosis of death, and deceased organ donation. He is chair of Nottingham's Ethics of Clinical Practice Committee and co-chair of the Deceased Donation Working Group for the European Platform on Ethical, Legal, and Psychosocial Aspects of Organ Transplantation. He served for 4 years as a member of the UK Donation Ethics Committees until its closure in 2016. Dr. Gardiner is also a chapter lead for Baseline Ethical Principles for the International Donation and Transplantation Legislative and Policy Forum, which is hosted by Transplant Quebec and co-hosted by the Canadian Donation and Transplantation Research Program. The registration for that event, which is in October, is currently open, and I'll post the link to registration for that in the chat. So with that, welcome Mahmud and Dale, and I will pass it over to you, Mahmud, and I'll share your slides. 1 minute here.
Thank you very much, Patricia, and thank you for inviting me to come and talk today as well. So I thought what I'd try and do is in just 10 minutes, share a little bit about Sharon's story and what happened through our organ donation experience. Explain a little too around, with the benefit of hindsight, how have I seen the process and what insights can I share with you from my side of the fence, really. And then finally, just to give you a sense of what organ donation has inspired me to do with my life and try and connect the threads with how the UK's process, or England's process in particular, in my case, has really helped to support what I now do within organ donation. See if I could have the next slide, please, Patricia. Thank you. So just to give you a sense of our background. So this is Sharon, my wife. We met in 1999 and we got married in 2002. This is our wedding picture. So you can see I'm the one looking petrified and a lot younger in that picture there. And though we were originally living in London, we moved up to Yorkshire in the north of England just before we got married in 2002. And Sharon was originally from the north of England as well. So our story happened on the 15th of March of 2004. It was a Monday morning and Sharon got up first thing in the morning when the alarm went to get ready for work as normal. She went into the bathroom to have a shower, and she just seemed to be taking a little bit too long time-wise. So I went to go check on her, and what I found was she had fallen in the bathtub. It was a bathtub with a shower over the bathtub, and she'd fallen down and pulled the shower curtain down and collapsed in the bath. So I thought she'd just fainted. So I rang our 999 number for an ambulance. the ambulance came really, really quickly, tried to revive her there and then, but said we just need to get ourselves off to hospital. So we went to our local hospital, Bradford Royal Infirmary, and we went into the emergency department there, and I had to then wait for them to try and treat her. They brought me into the room and basically said there's nothing they can really do. She died, and she died age 32 of a sudden brain hemorrhage as well. It was then I was asked by the emergency department team, had I considered organ donation? Now I must say, that is not our process today in this country, and probably shouldn't have been the process back then in 2004 either, for the clinicians to engage me as the family on organ donation straight away. But actually, in my particular case, it was all right, because organ donation was something we'd always spoken about. So I absolutely knew that she was a massive fan. She carried a donor card since the age of 16, and I knew that's something that she wanted to do. And it was a very brief conversation in the emergency department in order to then move Sharon's body to the ICU to warm her body up. And it's there I was introduced to a guy called Sean Willis, who was, back then, the title was transplant coordinator. And his job was to spend time with me as the donor family, to explain organ donation, and to really support me with the understanding of the process and answer any questions that I had. Sean's other job was to coordinate on the recipient side as well. So whilst he was engaging with me and talking to me about Sharon's wishes for organ donation, he was obviously lining up the recipients at the same time too. She took one breath unaided on that Monday afternoon, which basically meant they couldn't do the brainstem test that day. So I did end up having an overnight stay in Bradford Royal Infirmary, praying for a miracle, as you would do. That miracle didn't come, and they did the brainstem test the next day and confirmed that she had in fact died. And it was as severe a brain hemorrhage as you could get. So it was just like someone turning the lights out, really. That night, they did the transplantation. They retrieved her organs and obviously transported the organs and did the transplantation into the recipients. Her 2 kidneys and her liver were able to be used, and the liver obviously was split into 2 parts, a big bit and a small bit. And so 4 people got the gift of life, including a little boy of 1.5, who wouldn't have made it to the age of 2 without that transplant. It was his last chance saloon. So when I found that out the next morning, I was really overjoyed. And I know Sharon would have been too. She loved children, but only 1% of deaths happen in the way where organ donation is possible. So I genuinely believe she would feel quite privileged that she was able to support something that she believed so passionately about herself. If I could get to the next slide, please, Patricia. So that's our story. I'm immensely proud of what she did, but let me give you a little bit of a reflection, kind of with the benefit of hindsight. I knew what she wanted, so I was probably the easiest person as a donor family to have that conversation with, but it was still hard. It was still hard from a donor family perspective to go through that process and understand what you're doing. And I always tell people, ensure that you've told your loved ones your organ donation decision for selfish reasons. She protected me by telling me what she wanted. So in the midst of grief, I didn't have to make an extra decision and to agonize over whether that was something that we should do or not do when it's the worst possible time. I really don't believe I could have got through this without the transplant coordinator with Sean, who I mentioned. And I think it's really important to understand the role that he played for me. In a really cynical, not very caring way, if you don't mind me saying it, when you're in that situation as I was, that you go into hospital expecting that your loved one's fainted and you basically get told that no, actually they've died, it's hard to then transition your dialogue with the clinician who has not managed to save your loved one into, oh, let me talk to you about organ donation, when that almost feels like something for them when you've not had anything yourself. And the ability of Sean to come in as a separate role, just focused on me, really made a massive difference for me, because it separated the transactional, let me try and save your life, from the let me now build a relationship with you. And I think that's the really important thing about what's now called the specialist nurse for organ donation. That's what that snazzy SNOD title now stands for, specialist nurse for organ donation role has evolved. So the role today is focused only on the donor family. It doesn't now include the recipient coordinator side. So this person can now really build a not a time pressured relationship with the family. So they've got time, they build a relationship, and that's really important for me to have that separation as a donor family, to allow the donor family to ask the questions, not feel rushed, get to trust that person and make a better decision. And you'll not be surprised to know, and I'm sure Dale will tell you, that the consent rates are a lot higher when the SNOD is involved. And I really feel grateful for the process, because by having that engagement and that relationship, it enabled her wishes to be fulfilled, and therefore her legacy to be formed as well. And just if we flip to the final slide, please, Patricia, just to give you a sense of what this has allowed me to do. I am in awe of everyone involved in organ donation. I just think it's the most amazing thing, and it's had a profound impact on my life, really. So, you know, for the last 17 years, I've been sharing my story when asked to help people understand it, whether that's to try and drive awareness in communities, or to help with clinicians, whether they be nurses in ICU or doctors in the emergency department, to help understand what it's like from a donor family perspective as well. But as Patricia mentioned, I'm now an ambassador for NHS Blood and Transplant, an organ donation ambassador. And I mentioned the relationship that the SNOD actually allows you to have with them. And I genuinely believe that this is actually a really powerful thing, not just to help the donor family come to terms with the decision they're making and make the right decision as well, with that separation that I talked about, but that relationship lasts. And because that relationship lasts, it's enabled me to stay close to organ donation. So when there was an opportunity to come in and talk over the years and to become an ambassador now, it's kept me in the family, if you like, and I think that's really important. So what the ambassadors do, there's about 65 of us around the country, and it's a program that started in 2018, slightly hijacked by the pandemic in terms of how active we can have been over the last 18 months or so. But what it allows us to do is to be proper ambassadors from different aspects of organ donation. So there's about 19 or so of us that have, sorry, 22 of us, sorry, that have been, in my situation, donor families, 19 transplant recipients and 11 living donors, and another 13 or so healthcare professionals. And our job is basically to be passionate about organ donation, to have some lived experience, to be able to promote awareness and education of organ donation to all kinds of audiences around the country, including me being here today. You know, this came about through me being an ambassador and a request for someone to come and speak. I'm also on the organ donation committee for 2 hospital trusts, and I've actually, since November, become a non-executive director, a board director at my local NHS trust, Mid Yorkshire Hospitals Trust. And all of this I pin back to that moment of truth, if you like, albeit not with a good outcome in terms of Sharon's life being saved, but I saw just amazing care and an amazing legacy and an amazing gift of life being formed out of what was a tragic situation. And I know that she would have been very proud of her role in signing up to being an organ donor and carrying that card and telling me her wishes, most importantly. Thank you very much.
Thank you very much, Mahmud. I'm going to go crack straight on and do my talk, and then we absolutely can have questions at the end. But Mahmud, I met him actually early in my organ donation career, and actually the words he said, I still remember, and he quoted them to Snyder. As a clinician, I was the one who couldn't save his wife's life. And it was a specialist nurse who was the first person who was there for him alone. And I, as a clinician and an intensive care doctor, I've remembered that for all these years. And so thanks for sharing your story tonight. And hopefully, please ask us questions afterwards. So as you heard, I am one of the intensive care doctor. I'm also the associate medical director for NHS Blood and Transplant. I just want to quickly talk about, excuse me, it's a tickle, it's not COVID, how we made organ donation usual in the UK, because it's been a process. So just we love our graphs, but just a quick little graph, just to bring out the elephant in the room with this little graph of deceased donors and consent and authorization. Clearly, COVID has made a difference. What we've learned in COVID, I think is probably quite important, is that the donation foundations we have laid are quite strong. Every time COVID numbers get better, our donation rate and transplant rate bounces back to good. When we're overwhelmed, yes, it drops. And yeah, I think if I was to go back to 10 years ago, or even further back to the time of Mahmud and Sharon's story, that we would have stopped donation for the entire year and 18 months. There would have been no desire to continue it from the intensive care units. So I think it really is our foundations we've laid by changing us and making donation usual are strong. So you forgive me if I will just talk more about the actual numbers as we have them before the pandemic and what that represents. So we set ourselves explicitly in the UK to make donation a usual part of end-of-life care. And we sought to do that. And we made a massive effort in 2008. And you see, the consent and authorization rate didn't actually change, but the number of deceased donors rose and rose. And what happened in those first 5 years is we doubled the number of families we approached. In the past, we were sort of like, oh, how, they're a bit upset. Maybe we won't talk to them. We said, no, donation as usual. We'll approach everyone where it could be suitable, and the family will say yes or no as they are. So if you have a consent rate of 60% and you approach 100 families, you'll get 60 donors. If you approach 1,000 families, you'll have 600 donors. And it's a simple mass like that. And that was our experience. And we did it with embedding different individuals, what we call the triumvirate of the clinical lead, specialist nurse, and organ donation committee chair. And I'll touch on them later on. So we did well, we've increased, but the consent authorization rate had not changed. So we set ourselves in our next strategy to cause for a revolution in consent. And we did this specifically with our marketing and media campaigns, with training and a deceased donation simulation course for intensive care trainees, and a big emphasis on the collaborative approach, that talking to families is a collaboration between the doctor, the bedside nurse, and a specialist nurse for organ donation, and that is best practice. DCD, certainly donation after circulatory death, definitely played its part. And in the UK, we went from 25% in that early stage all the way to it's running consistently around 40% of all our donors. So we set out to make a cultural change, to make donation usual. And this was the byline that we launched everything and held to, especially for those as intensive care leadership and donation leadership. The donation is not what we were taught in the past. Donation is not something inflicted upon patients and families after end of life. It's a fundamental component of good end of life care. It is an end of life choice for people at the end of their life or their families to make. And that was a massive philosophical shift. We had some support where the General Medical Council regulates doctors in the UK, and in its treatment and care towards end of life document in 2010, effectively established a duty on doctors to explore donation and follow national procedures at the end of life. So the big cultural shift in all this was that deceased organ donation is not a transplantation issue. It's an intensive care end of life issue. And that's who we have to focus in. And this can be challenging. And people have to, were worried about this. Then, who do we work for if you're an intensive care doctor who's talking about donation? Who are you doing that for? You're doing it for yourself, the recipients, who are you working for? Well, this is just a little sort of analogy. There was once a man called Smith, and he had a very old laptop that was no good for anymore. And he'd heard that in overseas countries, particularly poorer countries, that they would take secondhand laptops and they could give them to school children and it could really help them. And he said, I'd like to do that. And he thought, oh, I know that Jones is on his way to that country. Oh, Jones, will you take my laptop and take it and give it to the children? And Jones said, sure, I'll take your laptop. I'll give it to the children. But as Jones was getting ready to go and get ready for his flight, he didn't pack very well. He just threw the laptop in. So when he got to the country, he discovered that the laptop was broken. So the question is, to whom did Jones have to say sorry to? Well, he had to say sorry to Smith because Jones had broken the gift. And when I think about who we work for, I'm going to let you in a little secret. The donation, I'm getting a bit ethical for you here, it's Kantian. It's not utilitarian benefit for other people. It is all based on the ICU doctor's relationship with the patient. It's because the patient wanted to be a donor, or through their family, we knew that they would want to support donation, want to help other people, that the moral authority for donation comes. So when I think about who do we work for, well, I can tell you directly, I work and always work for the patient and their family, and the offering of end-of-life care is just, donation is just part of that. We're just part of that. So then one of the lessons I had to learn individually in all intensive care in the UK is, so why do we keep apologizing? I'm really sorry to have to ask you whether you think about donation. Why are you apologizing? You don't apologize. I'm really sorry, but would you like any spiritual support here tonight? Or I'm really sorry, but is there any other family members who you'd like to come and give you a hand? No, you offer these end-of-life choices to people, and they will make their decisions and tell us what they need. And I think we had to beat out the apology, myself included. I had to beat my own apology out of my language, out of my mindset, because the offer of organ donation is a fundamental right of end-of-life care for those where it's clinically suitable. So how do we achieve that? That's the philosophy. Well, we achieved it by saying, refer everyone. Because without referral, you don't get anywhere. You never know about the organ donor register. You never talk about it. You never think about it. You have to make it routine to refer everyone. And that's what we seek to do. We seek to refer anyone where there's a plan to withdraw life-sustaining treatment in a mechanically ventilated patient. And different hospitals have found different ways of doing this, but the most important thing we do is sort of these four registered here. Sometimes we have a daily visit or a phone call by a specialist nurse for organ donation. A phone call if it's a smaller hospital that they're not actually embedded on that day, but there's always a phone call. Some hospitals have put it on their intensive care safety brief. You know, anyone with MRSA, anyone needs MRI today, is there any end of life care? Oh, there is. We might be going, well, make sure you ring the specialist nurse. We've focused very much on ICU nurse-led referrals. We try to decouple the referral from any individual clinician so that anyone can pick up the phone. In fact, all our nurses on their lanyards in my hospital have the little donation number that they can ring at any time for that. Some people don't like the word referral, we realize, because when you refer within medical circles, it sometimes means that you're handing over the treatment decisions or the care of the patient. So sometimes we just say, can you just notify them so they can make sure that they can marshal the resources needed to be there to talk to the family so there's no delay for the family. A lot of places review now every single death, as you do in a morbidity and mortality meeting, and they ask the question, was donation explored? Did we refer? What happened? And if you make that a routine, it becomes usual with this. So it's been a journey. But back in 2008, we had a 36% DCD referral, and it's gone to 93%. This is anyone withdrawing life-sustaining treatment on the intensive care. In 93% of time, we will refer to the specialist nurses, and for donation after brain death, or NDD in Canadian parlance, is gone from 83 to 99%. But the DCD one is just massive. Of course, majority of them will not be suitable. But human factors tell us to make something, just do it. To make something usual, just got to keep doing it usually. So, you know, we ask anyone, metastatic malignancy, you know, just ringing you, this patient's got metastatic malignancy. We know you don't want them. Yeah, thanks very much for that referral. Done. 5 seconds. But it just means that it's in the mindset. And then when you do have a genuine case, it's not forgotten. We learned something very important in the UK, which is quite remarkable. The more we referred, and as our percent of referral rate went up for DCD, voila, the DCD numbers rose accordingly. So, I thought we would plateau out quite a lot, because actually a lot of those referrals, we were picking the right ones to refer. So why do we really need an 80, 90%? Because surely they're the ones we're not referring because they're never going to be donors. No, our experience is as we increase referral, we have steadily, as you can see, increased the donor numbers in DCD. The other big thing we do, as we talked about, is this. And it's quite confronting to start with in our careers in intensive care, is that we have made it in the UK a standard of best practice and as a marker of quality that the family approach for donation is made collaboratively between the doctor, the bedside nurse, and a specialist nurse for organ donation. And we've found in our own research, and we've recently published a paper in Anesthesia, some incredible odds ratios for the influence a specialist nurse has. And these are thousands here. You can see for NDD approaches, 6,060, for DCD, 9,400 approaches in our cohort as we've gathered this information. And we have odds, so this is the odds ratio if the specialist nurse is not involved. So clinician-only approaches, absolutely shockingly low percent of consent rate in that circumstance. We consistently show that the patient's ethnicity, the patient's known wishes, and specialist nurse in the room are what makes the biggest difference for family consent. And of course, we can't change the ethnicity of the patient. We can't change what they may have said beforehand, but we can change who talks to the family. We're also putting we're learning a lot about those other aspects of when they come into the family, and we're bringing them in early. So this is from the same study. If the specialist nurse was not present when the neurological death testing results were told to the family, lower odds ratio. And importantly, they're very strongly showing us that the specialist nurse should be present for the withdrawal of treatment conversation. And we're doing that more and more, and we're up to 57% in that study, but that hides the fact it's over many years. Actually, that number is going up and up and up. And we can show you this is actually for presence for the donation approach rate that, back in 2012, 63% of the time, the specialist nurse was involved in that donation approach, and the other nearly 40% of the time, it was just a clinician alone. But by just pre-pandemic levels, 92.3% of the time, any conversation with a family about donation will be the specialist nurse will be present for them because they're the experts. They're the ones with the time to speak to the family. That is culture change that has not been easy, and it's dedicated a lot of people's efforts over the last sort of 10 years to achieve those numbers. But that's what we sought out to do, because that's what we think making donation usual is all about. But as you heard from Mahmud, it's not just about facts and things. It's also about changing the whole atmosphere of donation, both in the hospital as well as actually in the community. Mahmud, so the donation ambassadors have been extremely powerful in the community, as you heard from him. But these are some of the things we're doing. So in the hospitals, nearly every hospital in the UK now has an organ donation memorial. And just like there's a war memorial in every park, donation is one of the greatest gifts one person can give to another in peacetime. Maybe there should be a donation memorial in every single hospital, and we are achieving that. We have lift wraps in hospitals, you can see at the bottom left, which advertises the organ donor register. Now, I'm not sure anyone really, as a patient or a public, registers then and there. It's a message, I think, as well as that poster that's right there, right outside Costa Coffee, a coffee shop within the hospital opening area of actually my hospital. I'm not sure if they're not there for the public. They're there for hospital staff to know that donation is usual and what you need to do. We also have the Order of St. John Award for organ donation, which is a posthumous award given to every deceased donor. And it's given, effectively, the Order of St. John is an order of chivalry of Her Majesty the Queen. So effectively, it comes from herself down through the Order of St. John. And we have regional ceremonies, and we make this, and also generates lots of publicity and stories for these awards. And it's a very important way we say thank you to donor families. You also need the right people. And some of the things we've done to achieve that is the local organ donation team. And this really came out of the 2008 recommendation. And as I call this the triumvirate, we have every hospital, acute hospital, has a clinical lead for organ donation, CLOD, we love our fancy names, invariably an intensive care doctor, a specialist nurse for organ donation, but we also have organ donation committee chairs who are lay people who chair the committee and really focus in on making the message, making it usual, which is a really important aspect. We have had a relentless focus on data. So we ordered every single death under the age of 80 in our intensive cares throughout the UK. We get incredible amounts of data from that, and we show in our meetings, and it's publicly available, where hospitals sit. So if you're a little red hospital, in the red, that's your more than 3 standard deviations out for your referral. Words will be all added to you of why are you there? And that's it, and that will challenge people. We also have this letter to my chief executive and my medical director, basically telling us we were average for referral and average for specialist nurse presence. And we might have been this hospital there in the middle on the line there in the average mark. And average is fine because within 2 standard deviations, but still pretty confronting. No one wants to be average in front of their medical director and CEO. Everyone wants to be better. These challenge us. But as I sort of come towards an end, I don't want you to think that we've got it all right in the UK. We've got a massive journey ahead. We are still way off the Spanish levels, and we need to work on that. We have a new strategy, and in this new strategy, we're going to focus on organ utilization so that the gift is maximized, but we're also going to focus on changing the next philosophy. We think donation is usual in the UK. The next step is to make it expected. Not expected that it's mandatory, but it's expected that donation will be explored, will be offered. Society expects that, hospitals expect that, everyone expects that. One of the levers for that is our opt-out deemed consent legislation, which became into Wales in 2015, England in 2020, and Scotland in 2021. I'm just showing you the parliamentary votes then about how overwhelmingly supportive our politicians were as a representative of society for organ donation. So, that's absolutely incredible support. And we are in the process, the law, especially in England and Scotland, is only quite new. Culture change takes time, but to make donation expected, the expected part of care, expected thing on intensive care. You may be wondering what's behind me this whole time. What's all that about? Well, one of the great things we're doing is the Commonwealth Tribute to Life, because the Commonwealth Games are coming to England, to Birmingham in 2022. We've reached out to all the Commonwealth nations to sign a memorandum of understanding to share knowledge and expertise. Just knowledge and expertise. This isn't for organs sharing or anything. This is knowledge and expertise across the Commonwealth. We've got great support, 39 out of 54 Commonwealth nations. Catherine Butler is representing Canada from the Canadian Blood Service. I'm just looking at my names. I've got Joe Kim from the Canadian Transplant Society. Marcelo Cantaveric is representing the TTS. So, Canada is well and truly, like you always do, helping to lead the world. And my old Australian sort of homeland is also involved heavily. But we've got India, we've got Pakistan, we've got Malaysia, we've got most of the Caribbean. There's a fantastic groundswell. I urge you to check out the website and see how potentially transplant in Alberta can sort of leverage this when it comes close to the Commonwealth Games, because it's a whole Commonwealth initiative. And just finally then to summarize, making donation a usual part of end-of-life care. We needed in the UK, we needed to change our philosophy. We need to have the right people at the right time talking to those donor families, supporting donation in the hospital. And we needed to have a relentless focus on data. What we need to do now is just to keep going. Spain is up there. We've gone from here to here. We want to get up there. And what Spanish lessons have shown us is just keep going, relentlessly keep going. So thank you for listening to us. I'm sure Mahmud and I will be delighted to take any questions. And it's been our absolute pleasure to be with you this evening for us and daytime for you.
So I want to thank you both very much for 2 amazing talks. I've apologized to you via chat personally, but I apologize for the initial technical issues. There was almost a surgically timed power outage right as we were beginning there. So maybe I'll open up the floor for questions, and maybe I can start off with a question for Dr. Gardiner. With you know, this really is, that's a remarkable story of a culture change. And I can foresee that really being a culture change here, and a shift in sort of the mindset. This idea that donation is a standard of care for all of these patients. What was the pushback like that you faced on that, and how did you overcome some of the pushback? And maybe there was no pushback here. I can foresee that there being a little bit of pushback. So I'm interested in how you kind of overcame the obstacles there.
So I'm the second sort of national lead for organ donation, which has now been rebranded Associate Medical Director. And my colleague, Paul Murphy, who was the one before he retired, he led this charge. He used to be in front of the intensive care meetings, almost being booed during those meetings. And it was always, even people actually hung back because it was always the last session, the last day of the conference. People hang back to heckle him. So this has been a massive change. What changed people was two things. The first was the realization that this is actually not a transplant issue, and stop talking about transplant and talking about what sort of end-of-life care would you want for yourself, would you like to be offered. Stop being patronizing and picking and choosing families. It's not for us as doctors to choose that. It's something we just offer. We offer, we offer, we offer. And the answer will be the answer from the family. And then it's about having leaders, some champions within hospitals to make that message. The investment was in people, the specialist nurses in there, and the leads for organ donation. If I was to use a machine analogy, a car analogy, the specialist nurses in the hospital, they're like the petrol, the fuel. They just drive the process going, the advertising within the hospital. They're all the energy. What the leads for donation brought us, we're the oil and the grease. And without oil and grease, engines just seize, and you get nowhere. But we help to lubricate the relationships within the hospital, within our colleagues. And gradually, as you get enough people supporting this change, then those colleagues will find themselves on the outside. And then most people don't want to be on the outside, out of kilter with the culture of a unit. And then they will either retire if they're older, or they change. And that's how we've, it's a process.
And Mahmud, maybe I can ask you, what role do you see? Because we have obviously a lot of donor families that want to be advocates, and transplant patients that want to be advocates. What role do you see, or have you experienced donor families and donor advocates playing in this, cultural transition? How could you guide donor families and donor advocates to play kind of a maximal role?
Yeah, I think we bring the passion. This is something that we have clear lived experience in, and hopefully you can hear from, why am I still doing this 17 years on? I really care about this, and I'd like to think sharing a personal story is a trigger for people who have naturally there's apathy amongst the population, all populations, to have a conversation about death and have a conversation about organ donation wishes. Having a personal story to make people think about their own lives is immensely powerful. I mean, as Dale kind of mentioned in the chat right at the very beginning, and last week in the UK was Organ Donation Week. So I've done a lot of talks over the last week, and the most rewarding thing you can get is people giving you feedback at the end to say, you've inspired me to have the conversation with my loved ones to say what I want to do about organ donation. I remember actually years and years ago for NHSBT, and bearing in mind these are the people that work for the organization promoting organ donation, I did an event for them, a recognition event for them, where I spoke about my story, and the feedback on the back of that was about 6 or 7 people saying, I finally had that conversation that night. I mean, these are the people that work in the organization promoting organ donation. It's not the most natural conversation in the world to have. So I think we can bring that, and I think we can bring a little bit of, and I hope I'll get tough questions from you all, and uncomfortable questions, but being able to talk to people on the front line, whether they be nurses or doctors, and allow them to ask the unaskable questions that you probably don't want to ask in a live environment, to get a better understanding, I think is really, really powerful and helps to bring a better understanding of what it's like to be on my side of the fence for this as well. But bringing that perspective, that lived experience, that passion, the understanding of what it's like. And just to echo Dale's point, this is something that she really wanted to do. And I feel very grateful to the organ donation teams and the people I engage with, because it allowed her to do what she wanted to do. None of that would have been possible if I wasn't asked the question, if I wasn't approached. And that would have been denied to me. And it's a key message that you're enabling that end of life care and that end of life wishes and her wishes by asking. And we can always say no, but if you don't get asked, you don't get to fulfill that. And so I think it's just really important to understand those different perspectives that I can bring as someone that's been through it on that side of the fence, as well as understanding the processes and the culture and all those kinds of issues as well.
That's great, thank you. We're getting some questions in the chat here, so I want to get to them. Laurie West has a question for Dr. Gardiner. What's been the role of government in developing the systems that have made a difference?
So thanks, Laurie. So very helpful on that. So I'll talk before the change in the legislation. There've been cuts before COVID with regard to government funding. Some of the financial crises, as we all know, we weren't cut. And I think that's because we were seen as important. I mean, we know we can make the arguments we saved money for the health system because the dialysis is expensive and all the rest of them, we save lives. But there's been this undercurrent of support. And so we keep getting money from the government, or we don't get cut as much as other services, which is it's just quite a win actually in that. But as we increased donation and actually sort of more and more publicity and got the stories out like Mahmud, because they, in the past, donor family stories were sort of almost hidden, and now they're sort of out and front and center as they should be, because gifts and selflessness like that should not be just lost and forgotten. Almost the legislation became an inevitability as government go, we want to help you more. Well, how can we do that? And well, we like to write laws, so we're going to write a law to help you more. And I've got that sense that the government's come on board, not to say you were doing a bad job and we need to change the law, but if this is our way of saying we like what you do, the society likes what you do, and we wanted to do more. So we've had very, very close relationships with government through this, and actually we've actually only grown closer to them over time, which is a good thing.
Michael Corey has a question. Is there a role for nursing specialists from various cultural and ethnic backgrounds? I think your data highlighting that ethnicity was strongly associated with donation probability, and if so, has that facilitated organ donation?
Yeah, that's a great question. We would love that. We have struggled to recruit an ethnically diverse specialist nurse workforce. So ethnicity, it runs around about 14% of the UK population are from an ethnic background, and we have our specialist nurses. I think we're about 10 or 11% of them are from an ethnic background. We want to match the population. It's a stated aim. But we recruit from intensive care nurses predominantly, and we recruit from senior intensive care nurses. And unfortunately, not necessarily their fault as individuals, they're all white. So we are really working hard to try to sort of start earlier and sort of nurture people through and to really focus on this. We haven't got any data about any of what ethnicity the person was who approached the family. We sort of haven't been able to show that yet because numbers are too small, but something that is of interest to us. But more actually, we have a duty to reflect the population. So that's what I'm really sort of, we're working towards.
Could I add to that as well? I think Dale's absolutely right. There's clearly more to be done in terms of recruitment, but I think one of the great things about the SNOD role, the specialist nurse role, is that they are trained to understand the different ethnicity and religious aspects as it relates to organ donation. And I think that's quite important. So when you're approaching a family, no matter what your ethnicity as a SNOD, you still have that appreciation of the religious and cultural aspects when talking to donor families. And that is one of the powerful things I think that investing in this kind of role does allow you to have. It becomes part of the core training. And I think for people like me as well, from a ambassadors program, so yeah, Dale's right, 14% of the population is from an ethnic minority background. But in the UK, I think it's a third of the waiting list. So 33% are from an ethnic minority background, but only 7% of deceased donors. So you've got that mismatch that we need to address. And people like myself as well play a big role in engaging communities and talking about our own lived experiences through that ethnicity, religion, cultural aspects. I mean, it's not dissimilar really to vaccine hesitancy through COVID. It's myths, it's blame it on religion, it's WhatsApp groups. WhatsApp got a lot to answer for. WhatsApp groups spreading misinformation, being able to bring some sense and order to what does religion really say about organ donation, and why do people actually make the choice to donate. I think it's quite important, and we can all play a role in that, including us ambassadors.
I just was maybe wanted to ask a follow-up question to the, you're giving a talk to the Alberta Transplant Institute, and many members of our organ procurement organization are watching the talk. But one of the difficulties with the Canadian system is, we're very much regionally based. There's these organ procurement regions, which the integration at a national level, although it's evolving, is not probably there yet. And I'm curious that the UK situation, the level of national integration that you have, how critical was that national level view of things and the national level strategy? How critical was that to success versus one that maybe we'll be able to do it, make the push nationally, but I imagine a lot of the mechanics of this are going to be at a regional level with the different organ procurement organizations?
Yeah, great question. So we've got some challenges. It may be hidden a little bit, but Scotland, Wales, Northern Ireland, England, there is a different legislation for organ donation in each of those areas now. So it's not perfect, but we do have one organ donation organisation. We have one organ donor register. The funding each comes from the 4 governments into that. It's sort of based on population size is how we're funded. So we're grant in aid. We get a set funding from all 4 governments according to their population. And so all 4 governments have to agree that, and then they divide up according to population what we get. So there are some advantages. The potential donor audit, which I can just pick up Laurie's question there about the government funding for the collection. That's just part and parcel of NHS Blood and Transplant's work, is to actually do this audit. It was established many years ago now, and I've just put a link so you can see the latest. And if you keep an eye on that, the next few weeks we should have the latest version of our potential donor audit data out. So, I'm a big friend of Canada, and I have been for years. Been helping, and you've been helping us both versa, and with Australia. But the thing that you sort of compared to Australia and the UK, what you're really lacking, I think, is this potential donor audit across the Canada, where you actually have the data to really sort of share with and know what's happening, because the data will help you drive your changes, because you don't know whether it's working. And some of the data we shared today, and even more on that. It's not easy. It's not easy. It takes up a lot of specialist nurse time. Our data is all collected by specialist nurses. But what it does do, they say, is it gives them a reason to be on intensive care. It gives them a reason to talk to the clinicians about why this such and such didn't happen. It has a reason to go to the emergency department. We audit every death in emergency departments under the age of 80 as well. So it's emergency departments and intensive care. And actually it helps open conversations. So although it can feel like it's just a data collection, it's actually also one of the most powerful tools for reaching people. So it has that added benefit, and we've built the entire system on the data, and we still are. We're using that. So it's challenging, but it's something to aim for.
I just want to highlight as well that Mahmud put a link in the chat that is really worth visiting on the integration of belief and organ donation and sort of an NHS guide to that. So I don't know if you wanted to comment on that at all. That's very interesting.
No, I only to say that you know, I think NHS has done a great job just pulling together the views from each of the major religions, and obviously each of the major religions supports organ donation, and it helps a little bit of the myth busting and helps people get away from that initial reaction of, oh, my religion doesn't support it, without actually knowing and without actually understanding. So it's a great landing page, if you like, to encourage people to do their own research and understand that actually your religion does support organ donation.
And to add to that, one of the things we've discovered with our legislation change is, and this is sort of unexpected, but the conversations it's opened up with faith groups. Even if they're sort of, some of them, you know, some groups within certain faiths aren't supportive, but you know, we've still been to their meetings and to talk about it. You know, it has forced everyone to talk about it, and that's a good thing. And whether they say yes or no, at least they talked about it as a family. So as Mahmud says, that even selfishly, it's nice you need to know what your loved one wanted. And I think it's been a real powerful thing. We've never had better relationships with our faith groups in the UK as an organisation. But what the legislation change really opened up, because they had to engage with us because they wanted to know, they wanted to talk about it, they wanted to know what would change. We had to be there reassuring them. So, you know, big opportunity that which we didn't quite think about. That wasn't the sort of aim. That's been a secondary benefit of the whole thing.
Yeah, that's interesting. That's not an element of that legislation that I ever think about, but it certainly would force those conversations in a good way, I think.
Yeah, definitely been a good way. It's been very positive in with that.
Any other questions from anyone attending? Okay, well, we're coming up on the hour, so I just want to say thank you to you both for a remarkable personal story and for all the advocacy that you've offered, and to Dale for a really amazing achievement. I think we're all feeling a little bit jealous, to be honest with you right now, but hopefully we can use this as a model to build, because as you know, Alberta is always at the average or maybe a little bit behind Canada in terms of our organ donation rates. So we have a long way to go to get to this level, and it can be a model for all of us, I think.
Kieran, I think you and Alberta have got a huge future. And just if you can send any of your fuel over to the UK at the moment, we've got massive fuel shortages. So we don't do everything great over here. The shelves are empty. There's no fuel in the petrol things, and some of that's our own doing with Brexit. But I won't get too political. But anyway, it's been our pleasure to speak to you tonight. And we are friends of you, so reach out to us. We'd love, personally and in NHS Blood and Transplant, to support any of the work you're doing anytime.
Well, and on that note, I just want to put in a plug for as Dale is the chapter lead for the Baseline Ethical Principles for the International Donation and Transplantation Legislative and Policy Forum, and that'll be hosted by Transplant Quebec and co-hosted by the CDTRP, and that forum will be held October 14th and 15th. And I believe Patricia has put a link in the chat, and if it should be in there if people are willing. So, and just to highlight, next week's seminar will be a special discussion about with the Alberta branches of the Kidney Foundation, myself, Dr. Leanne Tibbles, and several patients and family members, all discussing the effect of the current situation in Alberta, the current COVID situation for transplant candidates and transplant recipients, and trying to move forward some advocacy on that front. So please join us for that. It's going to be an important discussion. And everybody just join me in thanking our two speakers for two remarkable talks, I think.